Hi, my name is Jennifer Cooper, and today I'll be presenting a case on Pityriasis rosea in an adolescent patient. Pityriasis rosea is an acute, self-limiting papulosquamous skin condition, most commonly seen in adolescents and young adults. It typically begins with a herald patch, followed by a generalized rash on the trunk and proximal extremities. PR is thought to have a viral etiology, most commonly linked to human herpes virus 6 and 7. This is supported by the fact that many patients report a preceding viral-like illness such as headache, malaise, or sore throat. Although the exact mechanism is not fully understood, current evidence suggests a T-cell mediated immune response with involvement of viral antigens in the skin. It most commonly affects adolescents and young adults. PR is not considered contagious and typically follows a self-limiting course. Patients may have a mild prodrome, such as headache or sore throat. The rash typically begins with the eruption of a single round or oval inflammatory lesion termed a herald patch that morphs into an annular scaly lesion. It is followed by the eruption of smaller maculopapular lesions with or without scale that spread along skin cleavage lines, forming a Christmas tree pattern. It may be pruritic, but is often otherwise asymptomatic and typically resolves within 4 to 6 weeks. This case involved a 15-year-old African-American male presenting with a spreading rash. The rash began on the face and spread to the trunk, chest, neck, and proximal upper and lower extremities. It was preceded by a sore throat. The patient reported itching but no fever or systemic symptoms and denied any new medications, sick contacts, or recent illness. The patient reported frequent sweating, heat, and sun exposure from participation in football and track. The patient had multiple oval salmon-colored plaques with fine scale on physical exam, widespread maculopapular lesions, including a larger annular lesion consistent with a herald patch. There were no vesicles or pustules and no mucosal involvement. Diagnosis is clinical, so no labs were performed, which is consistent with guidelines. Key differentials included tinea corporis, secondary syphilis, guttate psoriasis, and tinea versicolor, which can all present similarly to PR. However, these conditions were ruled out based on history, lesion distribution, absence of systemic symptoms, and clinical appearance. And I also provided a description of those differentials as well. Management in this case was primarily supportive with a daily antihistamine to control pruritus and an emollient to moisturize the skin to encourage healing. A short course of oral glucocorticoid was also prescribed due to the heavy, widespread inflammatory distribution of the lesions. The patient and mother were reassured that PR is self-limiting and typically resolves within 4 to 8 weeks. Education was provided on the methods to protect the skin, to avoid further irritation and prevent secondary skin infections. The patient and family were advised to follow up if new symptoms emerged, worsened, or failed to resolve. Now, guidelines emphasize that diagnosis is clinical and treatment is supportive. In most cases, resolve without intervention. Routine labs are not recommended. However, testing can be performed to rule out other conditions, such as a KOH prep, or syphilis screening to rule out tinea corpus or syphilis respectively if the diagnosis is unclear. A skin punch biopsy is rarely necessary, but if it is performed, it will show focal parakeratosis with or without erythematosus, spongiosis, perivascular infiltrate of lymphocytes and histiocytes, and occasional extravasation of red cells, supporting diagnosis. First-line management of the mild pruritus can include a topical medium-potency corticosteroid, topical antipruritic lotions, or an oral antihistamine. Although it is not recommended due to unclear or limited data for efficacy, treatment for severe presentations can include oral acyclovir, phototherapy, or a systemic glucocorticoid, which we did. Families may experience anxiety due to the appearance of the rash and concerns about contagion and spread, making education and reassurance key in managing PR. The management of the condition involves the nurse practitioner for the initial diagnosis, treatment, and management typically. Referral is usually only needed for severe or unclear presentations or unique patient populations. A dermatology referral is appropriate for severe, unresolving, or atypical cases. Patients who are immunocompromised should be referred to an infectious disease specialist for management, and pregnant women should be managed by a specialist due to studies linking PR to a heightened risk for spontaneous abortion. So that is all for my presentation today. I appreciate your time and attention during this interesting case, and my references can be found on the second slide. Thank you.